Hello everyone, and in this video I'm going to be talking about the medical history documentation. And so right now we're entering our third week as medical students in our first year, and we're being trained in our clinical and medical reasoning course how to take an annual exam history. And so, this being school, it's very scripted, and there's textbooks that have been written that are used by many other medical schools. And so basically the whole process of questioning a patient is something that's very, very standardized. There's this format called SOAP, subjective, objective, assessment, plan. And then within each of those sections, you've got subsections. Like within subjective, you're going to be figuring out the patient's chief complaint, the history of their present illness, if it's a problem-focused exam, and so on and so forth. And so basically you get these very, very rigid structures of ways in which you're supposed to handle yourself as a physician during a medical exam. And so, for me, it's a double-edged sword, because with the way I've kind of thought of medicine and my experience with medicine is that, I don't like canned, kind of robotic, scripted interactions. And we're also put under a time limit here. So we have literally 3 pages of questions to ask, and our entire grade depends on yes or no. Did we ask this specific question? Like, did we acquire your chief complaint successfully? Did we figure out the date of your last physical? Did we figure out if you had any issues with, tobacco use, or your sexual history, or those types of things? It's a bunch of just questions. And so we've literally got dozens of questions that need to be asked within a finite amount of time. And it's making it very difficult for the interaction to kind of seem natural and genuine, instead of more of a questionnaire or a survey that someone could have filled out on their own time. And, for me, I think this is something that I've seen a lot with, so Kaiser's one instance of a very large PMO where you are, or, whatever, some huge medical group that, you go there for a physical exam and you're going to be in and out in under 20 minutes because they basically have that whole thing down. It's as efficient as it can possibly be. The blood pressure is automatically acquired by a nurse before you even enter that exam room. And it just kind of makes the interaction with healthcare professionals seem so just formulaic and unhuman. And it, to me, is a very interesting thing to just think about, because it's like, you're going to want to have physicians who are able to engage with their patients and have strong patient-provider relationships. Like, you want to have people who, like, if you're a patient, you want to feel like you can tell your doctor anything. You want to feel like your doctor understands you. You want to feel like you're listened to. You want to feel like your feelings are valued and understood. And when we're teaching kids in medical school, here's dozens of questions you need to ask, and you're only going to get 18 minutes to ask them, and you get 9 minutes to type this up into a report that you're going to submit. And whether or not you answer all these in your report is going to determine whether or not you pass the class. It's very much like we're trying to mold people into these norms that will essentially propagate basically perpetuate this notion of these doctors who are basically like so high above you, and you're just going there to really be interrogated very briefly, get data extracted out of you, and then go home. And then, maybe you need some medication prescribed so they can push a pill at you. And so to me, it's something that I'm going through it because I have to. It's what you have to do. You have to learn this stuff. And I just hope that in practice, it will not be this generic and this bland and this boring, because I think it takes the life out of it from the physician side or the provider side. And if it's really just scripted, boring stuff the whole time, when you're a patient, it will come off, and you will literally, I mean, a provider will have memorized this list, so they're not going to be looking at a list necessarily, but they're just going to be talking and asking questions, and it's very hard to make it seem like a genuine human interaction, which I think is part of what makes healthcare and medicine something that's still special, in that it's people, it's the relationships that people have between other people, and how a doctor engages with a patient, their family, their community, to try to figure out, how can we apply a medical treatment or a service to better the lives, improve health outcomes of people. And when it's all scripted, it I think makes it harder to do that. And I think I'm missing a counterpoint to everything I'm saying right now, in that you're a first year medical student, everyone here, like, we all have to start somewhere. We need to make sure that within this finite amount of time that you're seeing a doctor, you're able to tell them what you need to tell them, and the doctor needs to make sure that they're asking the right questions, because we don't have infinite time with a physician. If you're a patient, like, you need to get in and get out because there's other patients who need to see that doctor that day. So to a certain degree, you do need a level of scriptedness and of time constraints. And so, part of my problem that especially as I'm like learning this thing, is like, some of the questions that we ask are literally things that are meant for, because of the billing. It has nothing to do with what you've said. It's purely because a doctor or a healthcare professional asking this question during an exam, regardless of whatever your answer is to this question, is something that makes that a more billable encounter between the patient and the provider. And in terms of confounding variables and the effect it has on the patient-provider relationship, I think that when we let accountants start having a say in exactly what is asked and how is it responded to, it can change things. So there's a lot going on here that is, above me and my pay grade and everything that I'm thinking about. Just, I'm new to this stuff, but, I just wanted to kind of like share my at least initial impression on, how this all seems. It's like it's like there's this cookie cutter thing. It's like you're supposed to be this. And, I think for people who want to think outside the box, or who want to, kind of be more spontaneous, it makes it harder to do it. Like, you literally have a script that you're supposed to go by right here. And so, I ask the question a lot, like, if I get an answer to one of these, billing questions that I'm supposed to ask, that is something that is concerning or alarming to me, am I just supposed to keep going and continue to ask more questions, have nothing to do with that, just, get that answer, move on, because it doesn't really matter, because we just gotta, get through to the next patient? Or is this something where you should say, hang on, like, let's talk more about that, because that's something that's important, because that could be something serious. Like, the thing that I'm worrying about as I go through this is, when we just have this very bland script, how do we still allow for all the edge cases that make us human, and all the edge cases that make medicine and health one of the most complex things in this universe? How can you script that? And so it's something that I find very kind of interesting. And I just wanted to share my thoughts on it. So I'm gonna wrap things up with that. Let me know if you guys have any questions, or share your thoughts if you want to. I'm curious to know what people think about this stuff. But yeah, thank you all for watching, and I will talk to you all next time.